I'm Dr. Rajiv Kovil, and I'm a diabetologist based out of Mumbai. I have two diabetes care centers in the western suburbs of Mumbai. And I'm here bringing you the second edition of the Diabetes News Nucleus. This is a unique initiative by MedTalks, and it's been supported by Mankind Pharma. Our endeavor in these MedTalks is to get you the best, the latest of whatever, whether it's research, medicine, drugs in metabolic care, so that you can get to know what is happening. And then a discussion with the expert of the month, which for today is Dr. Amrish Mittal. But before we go on to a discussion with Dr. Amrish Mittal, let me tell you some of the headlines which have captured imaginations of people in the metabolic space for the last 1 month. In the European Congress of Gastroenterology. And this has been here for the last 5 to 6 years, which is basically looking at duodenal mucosal resurfacing. What it actually means is that you are ablating the duodenal mucosa and then exposing new mucosa, and that's why it's called duodenal mucosal resurfacing. And thus the effect of nutrients on the mucosal resurfacing and the insulin resistant and the insulin sensitivity it causes. So studies over the last 4 to 5 years, multiple small pilot studies have shown that by doing DMR, that is duodenal mucosal resurfacing, you are able to enhance the insulin sensitivity. So whenever you play with the gut, what you actually would think of is probably a reduction in postprandial glucose. But this pilot study, which came out in the Gastroenterology Congress, looked at the fasting hyperglycemia going down, thus showing that insulin sensitivity would go down by this new procedure, and there's an HbA1c drop of more than 0.9%. The second headline, which is there, which we all have been experiencing, is the pandemic. And there have been a lot of debate that should be using a specific drug or injectable during this pandemic for diabetes control. A recent retrospective study on DPP-4 inhibitors emerged from Italy, which said that when a DPP-4 inhibitor is added to the standard of care, the mortality rate does become lesser by 40%. So probably whether a DPP-4 inhibitor has some role in reducing the virulence, we are not speaking about. This is an observational data, which does speak about the DPP-4 inhibitors, when it's added to standard of care as compared to standard of care, does reduce the mortality in these patients, and also mechanical ventilation. So some truths to the DPP-4 inhibitors to be used in these patients, not absolutely the drug of choice as such. Second, over the years, we've been having non-alcoholic fatty liver disease. And today, there is a meta-analysis which got recently published, which says that at any degree of fatty liver disease, irrespective of the metabolic features in terms of obesity or any other feature, patient is at very high risk to develop type 2 diabetes. It's almost double the risk of developing type 2 diabetes. So more severe the fibrosis score or more severe the NAFLD, the chances of developing diabetes is much, much higher. So the time has come that we need to treat non-alcoholic fatty liver disease, and non-alcoholic fatty liver disease may be the harbinger or the hallmark of a feature of metabolic syndrome in patients with diabetes. Now, to discuss further on non-alcoholic fatty liver disease and its role in type 2 diabetes and its connection to type 2 diabetes and its overall role in the huge cardiometabolic syndrome, we are fortunate to have Dr. Amrish Mittal with us. Dr. Amrish Mittal is the head of the Max Super Speciality Care Group of Hospitals. He's a head of department of endocrine in these 16 groups of hospital. He's also the president of the All India Institute of Medical Science of Gorakhpur. So a clinician par excellence, a researcher par excellence, and it's our good fortune that he's with us to discuss something which is very close to his heart and his passion on NAFLD and the progression towards diabetes and the rest of the complications or events which we occur in NAFLD. So over the years, we know that almost 20 to 25% of our population could have NAFLD, and probably 50 to 60% of our diabetics could have NAFLD. And NAFLD is very difficult to diagnose sometimes. And the first question to our expert is, Sir, if we diagnose, what are the diagnostic features of NAFLD, and what does a clinician do if he diagnoses NAFLD?
Thank you, Rajiv. It's a pleasure to be with you again and on this different forum this time. So, NAFLD has always been around. We've always known fatty liver. When I was a student, the paragraph, there was a paragraph in Williams on liver and diabetes, not even a page. And it said that you can get abnormal liver function tests sometimes in diabetes, but that hardly matters. It's of no significance. So for the exam, we used to prepare by reading gastroenterology textbooks like Sheila Sherlock's textbook, which had at least one page on that.
True.
So it was not part of, it was not on our radar. It wasn't like eyes, kidney,
Right.
feet, and now heart. But we do understand that fat in the liver, which was considered quite innocuous, and was called fatty liver commonly, still called fatty liver commonly. There is no doubt that it is the most important cause of chronic liver disease anywhere in the world, including in our country. And the prevalence is staggering. As you described, the numbers are so huge that you wonder who are the people who don't have, a fatty liver disease in your population of people with diabetes. So if that is the case, there is obviously more than just a chance occurrence of two common disorders. There is some link there. Quite clearly, when people with diabetes have a much higher prevalence of NAFLD than those without diabetes, people with NAFLD have a much higher prevalence of diabetes than those who don't have NAFLD. And both have a higher prevalence of coronary artery disease. So there is actually a triangle there. So it's not that diabetes is causing NAFLD, NAFLD is causing diabetes. It's like a vicious triangle or circle, if you will, which perpetuates each other. So what does it mean? What it means is that if you have NAFLD, it's a predictor of both diabetes and of coronary artery disease. If you have diabetes, you know it predicts CAD, but it also predicts NAFLD. Why? How? What is the connection? Where in one line, and we'll quickly move on to the next point. The important point to understand here is that NAFLD means there is accumulation of fat in the liver. The primary culprit is the free fatty acid accumulation, free fatty acid in the blood, coming from diet, coming from inflamed adipocytes, whatever. So this free fatty acids, this accumulates in the liver, and normally it is metabolized. But when it reaches toxic levels, then it either accumulates in the liver or leaks out. And either way, if it accumulates, it leads to release of certain toxins or cytokines from the liver, which aggravate the process of fibrosis. Right? So it's like it's the fat that is the primary sort of source of toxins here.
True.
And some of these patients will then progress to actual fibrosis and ultimately to cirrhosis and hepatocellular carcinoma. Now, a very small proportion will go down that path. The bulk of your patients will remain as fatty liver and
Fatty liver.
nothing will happen. But the numbers are so huge. If you talk of 77 million diabetics in India at 50% have fatty liver, even if 5% go down that path,
You're looking at
that's
a
a,
huge
that's
gap.
a, that's very bad. So this is one, and at every stage it's progressive. So, but it's not linear. You can go back and forth. And it's also important to remember that even in early or mid stages of fibrosis, you can still reverse it. This is dynamic fibrogenesis. It's not always, we always think we've been taught in pathology fibrosis, irreversible, keeps going on. But liver is a very vascular organ. It fibroses a little bit, then comes back. So the importance of that is that good intervention can stop it at the middle level, middle stage also, and not, necessarily only in the early stages.
So,
And of
so
course, if you reach the
if we have a pre-diabetic with NAFLD, do you think that if we treat the ectopic fat in the liver, we could prevent the progression towards diabetes? Do you think that we have reached a stage that probably liver is the kingpin in this metabolic abuse in our body, and this ectopic deposition of fat is telling us something, and we treat this, and probably we could help prevent progression towards diabetes?
it's very possible, but we don't know that yet. No
We
one has
don't know
shown
that.
that. But the fat is producing bad stuff. That's aggravating inflammatory sort of processes in the body, diabetes and inflammation, pancreas inflammation, heart. So all those things start happening. So it is possible.
It's
I'm
possible.
not in,
So,
but we don't
so
have a good enough drug yet.
I know we've got ectopic fat in the liver, in the kidney, in the fat, whether they are all creating hangama inside is something which we will find out in further research. So about patients with NAFLD, as you said, also progress towards HCC and cirrhosis. But another thing which actually occurs prematurely, like in our patients with diabetes, is its cardiovascular complications. So whether you're a diabetic or whether you have NAFLD, the event rate or the outcome seems to be cardiovascular. So what is the connection? What is the connection between this?
It's the same connection. Firstly, the risk factors for NAFLD are the same as the risk factors for coronary artery disease. So obesity, bad diets, or higher fat, higher glucose in circulating glucose, all those kind of things. They add high glucose diets. It's our diet that is the main culprit. Lack of exercise. This whole epidemic has come upon us only because of that, or largely because of that.
True.
So the same risk factors apply there, plus liver itself, as I said, if it's got bad fat in it, and if it's producing all those dangerous stuff, all the cytokines, that will also aggravate cardiac disease. As we know, a lot of cardiac disease is linked to inflammation. So
Mhm.
the whole thing is linked. Now, the question that you asked actually first was, what should we do? We've understood the genesis. ठीक है, तो करें क्या?
बिल्कुल.
What should we do? What should a clinician in the clinic do? So if you see, everyone orders ultrasounds, or someone does an OTPT and it's a little bit high, SGOT, SGPT, and you find that. So what is important for us as physicians, as diabetologists, endocrinologists, what is important for us is to pick up these cases. Pick up these because they come with no symptoms.
Absolutely.
I have had, how I learned about this is from some patients who were on my follow-up and were doing moderately well, not great, but and they had no clue, and one day they just bled. They had GI bleed and they found to have extensive cirrhosis, and I had missed it completely. This is 2 years ago. They were regularly following. I didn't suspect that minor OTPT elevation. We never an ultrasound, one ultrasound, done once in 2 years, something. So how should we suspect? There are 3, 4 clues we need to keep in mind. If you're a patient, of course, if you have fatty liver on ultrasound, such a patient needs further workup. But which of these patients? Everything is costly. Everything is time consuming.
True.
If you have an OTPT ratio, which favors OT. Normally, SGOT, SGPT means SGPT is more liver specific.
Absolutely.
But if the OT is higher than SGPT, antennae should be up, right? The second is platelet count. If along with that, the platelet count is low. So if you have OTPT ratio more than 1 and you have a platelet count that is low, then there is a suspicion rises immediately, especially along with an ultrasound showing fatty liver. So what we do in such cases is that we use the FIB4 scoring. There are many scorings for this. So we could use a FIB. I'm not going details of the score. You can find it anywhere. That utilizes these parameters: age, OTPT, and platelet count. That's all. And then it's a calculation. By
True.
that calculation, you can predict the risk. And if you have fall in that very high risk, it's a different story that you're already probably cirrhotic. If you find very low risk, then you can just follow up. But if you fall in the intermediate risk, as is the case in science and most things, then you need further investigations immediately. And there you need the test called a fibroscan. A fibroscan is now widely available, at least in the metros. I think
Mhm.
it is as important for a diabetologist clinic as is a fundus examination.
I agree. I agree with you.
So that's how we are looking at it. Screen them out like this. Look at these 2, 3 things quickly. It'll take you 5 seconds in the clinic to look at that. If required, do a fibroscan, and then accordingly a flow chart of what the fibroscan leads to. But that is important.
So this NAFLD is very similar to a chronic kidney disease in that respect, in terms that patient progresses through certain phases, and instead of actually reaching end stage renal disease or end stage liver disease, they probably get cardiovascular events. So
Right.
from that perspective, uh, should the treatment of NAFLD and diabetes, especially if you have NAFLD in patients with diabetes, should the treatment be an SGLT2 or a GLP-1? We come to the topic whether we could hit two disorders with one arrow. Is that would that be that if we suspect NAFLD or if we diagnose NAFLD in patients with diabetes, or vice versa, if a patient with NAFLD has pre-diabetes, Should we be treating them as patients with very high risk to cardiovascular events?
Yes, Rajiv, that's a very good way, practical way to look at it, an interesting way to look at it. And the first thing is that you always try to hit everything with one arrow, and that one arrow is lifestyle. The one thing that works for NAFLD in systematic studies is weight reduction, lifestyle. It works for liver, it works for heart, it works for everything. We know that. It works for
True.
diabetes, of course. So never forget that. So there's no rocket science in trying to figure out that I have to do something specific for my liver, specific for my heart, specific for my pancreas. No, the same lifestyle measures that we describe for any one of them apply to all the others. So that is number one. We should never forget that. Drugs for NAFLD have been a challenge. There has been no single drug that has been approved, not a single approved drug exists for by US FDA or others for treating NAFLD. However, if we are looking at long-term protection, and if we are looking at drugs that will do all of it together, so what are the two new groups of drugs that are so exciting in this? SGLT2 and GLP-1, because we know they have beneficial effects on the heart, and we know that they have beneficial effects on the kidney. And I think it was you who suggested, and I actually agree with it, that SGLT2, for example, is primarily a renal drug. Now that you knew more and more about it, I mean, it's absolutely clear. The other benefits are spin-offs. The
Absolutely.
basic action is renal.
It's
So
renal.
anyway, so these are drugs that have changed. But before we go to these two, one line about pioglitazone, because that's the only other drug that's been shown to be really effective in
Effective.
NAFLD. And there is no doubt there is data on pioglitazone, impressive data, pre-diabetes, diabetes, everything. Some histological data also, interesting, and which is also positive. But the issue with pioglitazone is other stuff, the weight gain, the risk of increased risk of fractures, the fluid overload, someone has a cardiac issue, then, heart failure prescription. So pioglitazone has actually taken a beating for its other non-liver effects. But if someone were to really study their liver effects, they're pretty impressive. So that's one. Now, coming to the meat of the topic today, that is the SGLT2 inhibitors. So, SGLT2 inhibitors, as you know, are drugs that act by pushing out glucose through the kidney. They sort of open the tap. The glucose leaks out, the sugar goes down. They also do other things. They help you lose some body weight. Body fat content goes down, right? So, if you do a body mass composition, you'll find that there is a change when somebody is on SGLT2.
Mhm.
These drugs we know have revolutionized the treatment of diabetes because they also protect the heart and now they protect the kidney. Probably, as you said, that's a primary action. They also, in the first study on human study on SGL2 inhibitors, we studied empagliflozin in what was called the ELIFT study and published it exactly 2 years ago, where we showed that a very simple, open label design. We looked at roughly 24 subjects, 24 or 25, with diabetics with standard of care, and 24 where we started them on empagliflozin. And we used the MR techniques, PDFF, to look at the liver. It's the most accurate fat measuring content technique, so that to the extent that people say for measuring fat content, it's better than even a biopsy. Biopsy will give you more information about fibrosis, but this will give you better assessment of fat content. So, and that showed a dramatic response in empagliflozin. It was like, these things are very exciting when you see an image before and after, and the fat has just gone. It showed dramatic response. So, say 16% mean fat before treatment and 11% after treatment. So 5% gone.
Oh.
So, and both groups had similar lifestyle advice. So it was very impressive. And there was some change in liver enzymes also. And subsequently, numerous studies on DAPA, on CANA, and others have shown that there is this phenomenon that we lose liver fat with this. Some of them have shown liver enzyme impact, some have not. Some have shown actual histology, but the numbers are very small. And actual histology definitely reduces inflammation and fat, and some evidence that fibrosis may also be reversing partially, but not, we can't conclude on that, right? So that's where SGLT2 is. So we are hitting several, we're killing several birds. Killing birds is not nice, but whatever, we are achieving several targets with one arrow.
Very true.
Okay,
Very
which
true.
means that with one arrow, in addition to lifestyle measures, with SGL2 inhibitors, we are lowering glucose without hypoglycemia and helping people lose weight. We are protecting their heart definitely from heart failure, possibly from coronary events, but heart failure for sure. And we are protecting their kidney, micro to albuminuria to CKD, all those things. We are doing that. And we are also reducing the fat in the liver. So
Very
we are
true.
actually targeting. So
Multiple.
it's very exciting finding.
Very exciting. Very exciting. I agree with you. So when do you think that people in the metabolic space should refer this NAFLD to a hepatologist? When does the hepatologist come in picture?
I think that's again a brilliant question. Moment you find evidence of clear-cut fibrosis on a fibroscan, you must get an hepatology opinion. And of course, if it's further down the line, advanced fibrosis, it becomes their patient primarily sometimes. So that is why it's very important to decide. You can't send everyone to a hepatologist,
True.
every fatty liver. You can, but it's a very good way to screen with a fibroscan. If we do that, we have the power in our hands to decide who requires. Otherwise, they go to a hepatologist, then get a fibroscan, and then another, and then they're sent back. Instead of that, we can screen like now we do. I mean, crudely, but with a fundus camera, we screen and if there's any abnormality, ophthalmologist. So that's how, and patient compliance improves if you do that. So I think that's how we should look at it. And SGLT2 inhibitors will be useful drugs, as will be GLP-1.
So to clinicians who would listen to us, so first we would do a probably a fib scoring and then probably grade the patient.
Yes.
And then which patient would we tell them to do a fibroscan, because fibroscan is 12 to 13,000 rupees. So which patient do you
Oh,
think that
it's much cheaper now, I
is
think.
much cheap?
Yeah,
Uh,
yeah, yeah. Now,
so, but
now then it's much cheaper. Yeah, but
if
still, it's yeah, it costs
still
money.
it's
Yeah.
so which patient based on the scoring FIB4 scoring we would direct them to a for a fibroscan, or should we,
Yes,
and when do we
you
repeat it?
should do it on based on FIB4. I have a flow chart. I can share it with you.
Hmm.
You should do it based on the FIB4 score. There are other ways of doing it. There are numerous scores, but we
True,
just
true,
got liked the FIB4 score. It was easy also, and
true.
it seems to work well. Right now, my former institution, my erstwhile colleagues there, they're actually looking at something that we started there when I was there is screening all of these diabetics with the FIB4 score and telling you how much you pick up and how much you don't.
Mm-hmm.
So that would be more information. These studies are primarily for drug usage to see impact of drug. But yes, so in one line, you will do a FIB4 score based on these simple parameters. Based on that, if you fall in the intermediate zone, you will ask for a liver fibroscan. Based on the fibroscan, if you fall in the intermediate zone, you will be, well, based on the intermediate or advanced zone, you go to a hepatologist.
So
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 I think that's how we should do.
fantastic clarity. So people listening to sir, it's very simple. You first screen the patient. Don't let the patient who has a fatty liver or a sonographic appearance of fatty liver go out of the clinic without you actually working up the patient. That's the number one message. You need to work up that patient, probably do a fib score or any other kind of scoring, then grade that patient. If you feel that based, as sir said, has got some intermediate risk, go do a fibroscan. If you find the risk higher on a fibroscan or you see fibrosis, let him go to a hepatologist. The other thing is that patients with NAFLD, with diabetes, would also have cardiovascular events. So, in the last decade or so, we all have learned a lot of cardiology than what we learned in our MBBS and post graduation. We've all become partially diabeto-cardiologists and then became diabeto-nephrologists. Now we have to become diabeto-hepatologists. So that's extremely important. That diabetes is one disorder which affects every organ of the body, and we are learning more and more as years go on and as research goes on. So nephrology, cardiology, and hepatology are becoming more important in our practice than ever before, and that's the key message that we would like to give all of you. So one take home message to people who are listening to you.
So the important message I'll carry on from where you left off. That is that actually when I started my career, we were pure straight endocrinologists. But as our understanding of diseases has evolved, diabetes is just an index, which is associated a part of a big loop.
True.
So actually, we are all now functioning as chronic care physicians. What distinguishes now a successful endocrinologist, if you will, from someone who's just, okay, in the public eye and in patient care, would be the one who gives attention to chronic care. So you have to be a chronic care physician, regardless of whether you are an endocrinologist, diabetologist, or a physician. You cannot be just looking at the glucose or just looking at the liver or just looking at this. You can't do that anymore. And then you have to, so as since the best recognized condition in these, because of all the efforts of everyone, including people here, is diabetes. So you should treat diabetes as an index condition because of which the patient has come to you, and not as a diagnosis in itself. It
True.
just reflects one part of the whole spectrum. So when
True.
you're treating diabetes, you have to look at all this. That
Everything.
is my message.
Thank you so much. So I hope all of you all had a good understanding on this topic from somebody who's actually a domain expert on NAFLD and its progression towards all these other events and other complications. We will be back next month with another broadcast of what is happening new and exciting in the metabolic space. Till then, goodbye, colleagues. Till we see you next time. Bye bye.